Welcome guys, I will be covering the hematology topics and I will start with the hemolytic anemia first. Now this will be divided into 4 videos mainly. First video I will talk about introduction, second I will cover the inherited causes of hemolytic anemia, then acquired causes of hemolytic anemia, and lastly paroxysmal nocturnal hemoglobinuria. Now coming to the topic of anemia, so how can anemia, which is nothing but a decrease in hemoglobin content in the body, can occur to a person? It can occur due to decrease in production. Number one, decreased in production. Number two, it can be caused to increased destruction. Or lastly, it can be any other causes which leads to acute blood loss resulting into anemia, right? This decreased production is usually nutritional deficiency related and has been already covered like iron deficiency and vitamin B12 deficiency in the other videos. So I will cover about the increased destruction part that is associated with hemolytic anemia. Now, where is RBC produced? If you consider the production factory for RBC, it is nothing but our bone marrow. It produces freshly prepared red blood cells and release them in the circulation. Once its function is over or this red blood cell gets denatured with time for some reason, it gets sliced in specialized organ like spleen, or sometimes this lysis can occur inside the vessel itself, known as the intravascular hemolysis. This can be considered the total life cycle of RBC and it is around 120 days. Now, anemia at the level of factory itself or bone marrow defect is all practical purpose can be considered due to hypoproliferative nature, that is decrease in work of the bone marrow, hypoproliferative anemia. And anemia at all other places are considered to be a hyperproliferative. This hyperproliferative can also occur due to defect of bone marrow itself or due to decreased in the nutrient supply to bone marrow. And this hyperproliferative, apart from lysis, can occur due to acute blood loss when there is trauma to the vessel wall and there is blood leaking. Now, why it is considered as hyperproliferative? As when there is lysis at the level of the extremities or in the vessels or the spleen or acute blood loss, bone marrow gets overactivated and starts to work more, and that's why the term hyperproliferative comes. And when bone marrow was working more, obviously immature form of RBC will be released in circulation. So in peripheral smear we can identify, or blood examination we can identify by counting the immature form of RBC, that is nothing but reticulocyte. So retic count will be increased in case of hyperproliferative anemia, whereas in case of hyperproliferative anemia, that is immature form, will decrease, that is retic count will decrease. Okay, all right. So this is one way of differentiating between hemolytic anemia and other causes. Now, if we check hemolytic anemia, it can be divided. Hemolytic anemia based on cause can be divided as inherited or acquired. Based on site of lysis, it can be considered as intravascular or extravascular. Based on the mechanism of defect, it can be considered as intracorpuscular or extracorpuscular. Most of the inherited ones are usually intracorpuscular in nature, whereas most of the acquired ones are extracorpuscular in nature. Obviously, exceptions are there to this rule. Now, for a clinician, important thing is to note whether hemolytic anemia is acute, chronic, whether it is mild, severe, whether hemolytic anemia is transient, that is for only few times, and whether it is recurrent or persistent. Recurrent or persistent. Alright. Okay. So let's check the Harrison table. It is based on the classification of hemolytic anemia. You can see inherited causes mostly are intercorpuscular, but there is one exception, that is familial hemolytic uremic syndrome or atypical hemolytic uremic syndrome. And acquired causes mostly are extracorpuscular, apart from only one, that is paroxysmal nocturnal hemoglobinuria. So these exceptions are the one that can be asked in multiple time in exams, like which all of the following are causes of acquired extracorpuscular hemolytic anemia except, or all of the causes are causes of inherited intracorpuscular hemolytic anemia except, like all except question can be framed from this exception. Now these two exceptions has a one common factor, that is both are complement mediated, and we will see subsequently in next modules. Alright. Okay. So how usually the patient present to you of a hemolytic anemia? So as there is anemia, obviously first and foremost clinical feature will be there with pallor, and symptoms of anemia like fatigue, tiredness, lethargy will be there, and on examination hemoglobin value will be low. Beside differentiating feature of, apart from this, other anemia is that as there is lysis of hemoglobin, bilirubin is secreted in the blood. So bilirubin level will increase and it will manifest as jaundice. So pallor plus jaundice is one of the clinical feature of hemolytic anemia, and this bilirubin is mainly the unconjugated than the conjugated. As unconjugated is more, it will be excreted in urine, so it will give a dark coloration, dark yellow urine. Sometimes patient, if there is hemoglobinuria associated, seemingly seen in intravascular ones, they can complain of, patient can complain of cola colored urine. Then as there is lysis of RBC, the site of lysis will enlarge. So obviously there will be splenomegaly in case of extravascular ones. Alright. Now what will happen at the level of bone marrow? Now mainly in the congenital ones, congenital hemolytic anemias, bone marrow will overfunction from the childhood, from the very beginning. So due to the bone marrow overfunctioning, there will be associated skeletal deformity may be seen. Skeletal deformity may be seen, as well as immature form of red blood cell will be secreted in the circulation, resulting into increase in MCB, MCH, increased retic count. Also we may find nucleated RBC. Alright. Now mainly in case of let's divide this intravascular and extravascular. How to differentiate these two type of anemia? Now what happens is that when there is cell lysis, LDH is secreted. So when there is lysis of the RBC, LDH will be secreted, and if you measure serum LDH, it will be high in case of intravascular, like around 10 times more than the normal. Whereas in extravascular, site of lysis is not the blood vessels, it is in the spleen or other tissues. That's why serum LDH will almost be near normal. Then this senescent hemoglobin binds with hepatoglobulin and is excreted in urine. This results into hemoglobinuria. So if we measure serum hepatoglobulin, it will be low in case of intravascular, whereas near normal in case of extravascular. Spleen will be seen in case of extravascular, whereas spleen will be almost normal in case of intravascular. Alright. Okay, so let's check the table from the Harrison about the features common to most patients with hemolytic anemia. They are usually present with jaundice and pallor. Spleen will be enlarged and there will be skeletal deformity. So this enlarged spleen may lead to condition of hypersplenism. Hypersplenism is state of overactivity of the spleen resulting into decrease in the count of the other blood count, that is decrease in hemoglobin, decrease in TLC and decrease in platelet, leading to pancytopenia. So initial patient of hemolytic anemia who later on develop splenomegaly can also present with pancytopenia and spleen. Then hemoglobin obviously will be normal to severely reduced, MCV, MCH increased, retic count increased, bilirubin almost always increased and mostly unconjugated one. LDH increased with intravascular hemolysis and hepatoglobin reduced to absent if hemolysis is at least in part in intravascular. Alright? Okay. Now, clinically, if hemolytic anemia is transient in nature, hemolytic anemia, if it is transient in nature, it will not cause any sort of important symptom to the patient apart from requirement for erythropoiesis factors like folic acids, supplementation, and if it is recurrent or persistent, there will be time to time rise in bilirubin, which can give rise to pigment gallstone. In fact, this important part is the usual presentation of hereditary spherocytosis. Hereditary spherocytosis does not lead to severe anemia at all. Hemoglobin level ponders around 10 to 11 and usual presentation is 11 to 12-year-old person who is having hemoglobin 10 to 11 and presented with jaundice and gallstone. On evolution it was found to be pigment gallstone and later on peripherals may have revealed hereditary spherocytosis. These are the usual presentation of hereditary spherocytosis. Now as you can see, hemoglobin are modified RBCs, and that is RBCs are modified cells. So what does it doesn't contain? It doesn't contain nucleus, it doesn't contain mitochondria, or it doesn't contain ribosome. Alright, so as there is no mitochondria, it is dependent on anaerobic glycolysis for energy production, and as there is no ribosome, so it cannot synthesize protein. Therefore, if there is wear and tear in the cell membrane, as you can see the cell membrane of RBC, it contains multiple protein. So if there is for any reason wear and tear, this RBC cannot synthesize its own protein and correct it, resulting into subsequent lysis and death of RBCs. So for energy purpose, it is completely dependent on anaerobic glycolysis, that is Embeden-Meyerhof pathway. Just remember this to be an anaerobic glycolysis step. Alright, now important part is that here NADP helps to maintain, here as you can see, NADP helps to maintain the RBC hemoglobin in the reduced state, that is hemoglobin in the reduced state, and NADPH, here NADPH, it reduces the glutathione, and as it reduces the glutathione, it helps to protect against the oxidative state, protects against oxidative stress. Alright, other important point about this anaerobic glycolysis pathway in case of RBC membrane is about 2-3 BPG. At the state of decrease, this is a regulator of oxygen affinity, right? So when there is oxygen delivery is hampered at the tissue level, 2-3 BPG level rises, and it compensates for anemia. Stimulator for 2 to 3 ppg is obviously anemia itself as well as hypoxia. Now, different enzyme defect in this pathway can result into improper functioning of the RBC and anemia, leading to hemolytic anemia. So, what are the important enzyme defects? Most common one is here, that is G6PD defect, followed by the pyruvate kinase, this one pyruvate kinase, followed by glucose phosphate isomerase, and followed by the other causes. These are the enzyme defect or enzymopathy leading to inherited intercorpuscular hemolytic anemia. Alright, now let's check the RBC membrane. RBC membrane is primarily formed inside by spectrin, alpha spectrin and beta spectrin monomer, and it contains two sort of complex, ankyrin complex and junctional complex. We will review this RBC membrane structure time to time to understand about the different pathophysiology of different type of anemias. But for, let's say, if you say at the junctional level, band 3 is the most abundant protein here, and it acts as this band 3 acts as anion exchanger, and this is acting as anion exchanger, and when the red cell ages, it accumulates products and gets denatured, and probability of this band 3 exposure on cell surface increases, resulting to increased site for binding for antigens like anti-band 3. That binds to the band 3, resulting into opsonization and gives a signal for phagocytosis by spleen and liver. Now, this is a normal pathophysiology, normal physiological process. When this process is accelerated, it leads to severe form of hemolytic anemia. Now, what is the life cycle of RBC, guys? Total life cycle is completed around within 120 days, and as this life cycle is finished early in case of hemolytic anemia, obviously it is decreased in hemolytic anemia, or we can call that RBC turnover increases. Now, what is the best test to identify RBC life cycle? Best test to identify is obviously 51 chromium PET RBC and checking for the radioactivity. However, it is not done in practically. In case of hemolytic anemia, this radioactivity will fall very quickly over weeks. Now, as this increased turnover, and mainly in the chronic stages, in intravascular causes, there will be hemoglobinuria. So hemoglobin will be lost in the urine, resulting into, and what is contained in the hemoglobin? It is heme and globin portion. Heme contains mainly the iron, resulting into loss of iron and secondary iron deficiency anemia. Therefore, all intravascular hemolytic anemia should be supplemented with iron. And when it is extravascular in nature, now in extravascular, hepcidin is suppressed. Here hepcidin is suppressed. So there is no iron loss practically, as nothing is lost in the urine in case of extravascular. So there is increased iron absorption plus no loss of iron from body, and this patient are in need of multiple blood transfusion because of anemia thing. multiple blood transfusion. These all together can give rise to a state of iron overload. Iron overload, and if the problem is underlooked and iron chelator is not applied to the patient, it may lead to secondary hemochromatosis and subsequent liver cirrhosis or heart failure. Alright, so these are the usual complications of hemolytic anemia. Now from here we come into the concept of compensated hemolysis. Now remember, hemolysis itself is a potent stimulator for erythropoiesis, and this erythropoiesis is mediated by mainly by two molecules. One is the erythropoietin and other being the hepcidin. Now in case of hepcidin will be inhibited in this case and erythropoietin will be get overactivated. But if the patient having hemolytic anemia or hemolysis ongoing, along with the patient is case of CKD where erythropoietin cannot be produced or there is increased physiological requirement as in case of pregnancy, or there is ongoing any infection in the body, for example parvovirus B19 infection, this all can trigger this state of compensated hemolysis to a state of hemolytic decompensation and hemolytic anemia. So this notion is very much important from the diagnostic point of view because a patient with hemolytic condition, even an inherited one, may present without anemia because due to the hemolysis, erythropoiesis is high and this is compensated. This anemia is compensated easily. Now it is also important from the point of view of management because compensated hemolysis can turn into decompensation at any point of time. That is, anemia may suddenly appear in certain circumstances like chronic kidney diseases, pregnancy, parvovirus B19 infection, folate deficiency or nutritional deficiency. That is, compensated can turn into decompensated anemia. Alright, okay. So that's all about introductory part of the hemolytic anemia. In the next module, we will check about the inherited causes of hemolytic anemia, and we will cover about the hemoglobinopathies, enzymopathies and membrane cytoskeletal defect, as well as we will look into the familial hemolytic uremic syndrome. Okay.